This week we're going to start looking at a number of different diseases that affect the heart. And there are a number of different ones that are discussed in your book, and we don't have time to cover all of them. There's just a few of them that we're going to be focusing on. But let me just kind of give you the lay of the land of all the different types of heart disease there are out there, and then we'll get into talking about the ones we're going to be focusing on. So types of heart disease can include things like congestive heart disease, which is something we're going to be talking about in just a minute, so you'll learn more about what that means very quickly. Ischemic heart disease, which of course means lack of blood flow to tissues in the heart. There's hypertensive heart disease that's related to having high blood pressure and the impacts it can have on the heart tissue. Valvular heart disease, which relates to malfunctioning of the valves of the heart. Pericardial disease relates to troubles with the pericardial sac that surrounds the heart, and congenital heart diseases are those which people are born with. Now we're really only going to be focusing on the first three up here and really kind of not worrying about the others over the course of this week's lectures. So let's start out with congestive heart disease. Well, actually, before I do that, let me just give you a little lay of the land on heart disease. Most of you probably know that heart disease is a very common condition in the United States. If we look in industrialized countries like the United States, like the United Kingdom, etc., heart disease accounts for somewhere on the order of 40% of all deaths. And that's more than twice the number of deaths that are caused by all cancers put together. So all these different types of heart diseases are very, very common types of diseases that occur in the population. So it's good to know and understand these because they account for such a large number of deaths in industrialized countries. Okay, that being said, now we can go on and start talking about congestive heart disease. So what is congestive heart disease? Well, in a nutshell, congestive heart disease happens when the heart cannot pump an adequate amount of blood to keep this body sustained and going in terms of appropriate levels of oxygen delivery and nutrient delivery. So if the heart begins to reduce its amount of blood pumped, we have congestive heart failure. And usually the type of congestive heart failure people experience is called systolic heart failure. Now there is a type called diastolic I'll talk about in just a second. Systolic heart failure is by far and away the more common of the two, and it involves a loss of contractile function. So in other words, the heart loses its ability to contract with power, and as a result, of course, that means less blood is getting circulated throughout the body. Therefore, you have met the definition of congestive heart failure. Diastolic heart failure is much less common. It's pretty rare. It involves loss of the ability of the heart to relax. Usually you see this more often in older female patients, and they're typically patients that have diabetes, mellitus, or hypertension. But again, not the more common type. Now, before I talk about the etiology of congestive heart failure and about its impacts, let me just remind you that the cardiovascular system is a closed system, and that it involves blood entering into the heart as it returns from the body from the superior and inferior vena cava into the right atrium, traveling through the right ventricle, up into the right and left pulmonary trunk, pulmonary arteries. The blood gets circulated out to the lungs, which is the pulmonary circuit, picks up oxygen, and then is returned back at the left atrium through the right and left pulmonary veins, travels down through the left ventricle, and then exits out into the systemic circuit through the aorta, and then of course it goes and circulates around wherever it needs to go in the body before returning to the heart. If any of that does not ring a bell for you, or if you at all feel shaky on the anatomy of the heart, I strongly suggest that you stop this recording right now excuse me, and go back and listen to my Bio 202 lectures on heart anatomy and physiology before you continue, because if you don't have the circulatory system and the anatomy of the heart down and the physiology, you're going to have a very, very difficult time following what I'm going to talk about next. So I'm very serious about that. If you feel at all not confident, stop now, go listen to that, and then return to this lecture. So the etiology or the cause of congestive heart failure can be a number of different things. Sometimes people have endocarditis, which is a type of valve failure. So for one or another reasons, one or more valves fail, and so we're not getting an adequate movement of blood through the systemic or the pulmonary circuit. A lot of times it's because of some sort of abnormal loading. Maybe the person has hypertension, for example, or they are hypervolemic. They have greater than normal levels of blood volume, and that can cause congestive heart failure. And we'll look at some of these more closely later on. Regardless of the etiology, what happens in congestive heart failure is we can get two different processes occurring, one called forward failure and the other called backward failure. Forward failure means that all of the places that are ahead of or downstream of the problem area don't receive enough oxygen. So imagine that if the left side of my heart is not pumping adequately, it's not circulating sufficient amounts of blood. Of course, it would make sense that forward from that point, the systemic circuit is going to be having difficulty receiving adequate amount of oxygen, and so it's going to become ischemic, and that decreased cardiac output is going to be impacting those organs. Now, eventually, what's interesting is that forward failure can eventually also lead to what's called backward failure. Now, backward failure just simply means that if you think about it, if the left side over here is not pumping sufficiently, you're going to start to get a buildup of blood behind that point, right? The blood in the lungs is not going to get moved forward into the systemic circuit, so the lungs are going to get a buildup of blood that's going to back up into the right atrium and the right ventricle. That's called backward failure, and it leads to congestion of the venous circuit. Now, there's a number of different ways that the heart can compensate for this lack of or reduced cardiac output. And in the beginning, many of these will actually help compensate. They really do work. But the important thing to note about the next two slides, when I talk about these compensatory mechanisms, it's important to remember that almost all of them over the long haul end up failing. So even though in the short term the body can compensate for the loss of or for the reduced cardiac output, in the long run, it's unable to compensate for it. So here are some ways in which the heart can compensate when cardiac output drops. There is systemic-wide in the body an increased release of norepinephrine, and that is because when perfusion into places like the kidneys or the brain drops off, the brain initiates the release of norepinephrine, and the kidneys initiate the release of renin. And both of these, as you'll remember, are great at elevating blood pressure and blood volume, which elevates blood pressure. And so, and in the case of norepinephrine, it also helps to directly increase the strength of contractility of the heart muscle itself. So great in the short term, we elevate blood pressure, we elevate blood volume, and that does help compensate in the short term for reduced cardiac output. But these both generate a vicious cycle because they increase preload, they increase afterload, and over time, that increase in contractility drops. You get actually a drop in contractility, and that's because the myocytes in the heart actually downregulate their number of norepinephrine receptors, so they become less sensitive to the high levels of norepinephrine. Now, if you don't remember what preload and afterload are, again, I'm going to tell you, stop right now. Go back to Bio 202 lectures, listen to the lectures on the heart. You've got to have these terms down and know what I'm talking about, because otherwise you're going to be absolutely lost in these lectures. So if you don't know what those terms mean, you need to go back and learn them, remind yourself of them, and then return to this lecture. Now remember, with the renin pathway, if the kidneys release renin, that sets up a cascade of hormonal releasing events. It includes things like renin converts a inactive version of a protein found in the plasma called angiotensinogen, and it converts it to angiotensin 1. That angiotensin 1 then circulates around till it gets to the lungs, where it encounters angiotensin converting enzyme, or ACE. It's converted into angiotensin 2, and then that induces vasoconstriction, which of course would help elevate blood pressure. It also induces the release of aldosterone from the adrenal cortex, and you'll remember aldosterone retains sodium and thus retains water. It causes the kidneys to retain sodium and thus to retain water. So that helps to elevate the blood volume, which also helps to elevate blood pressure. Now, another way that the heart compensates is through the release of atrionatriuretic peptide. And this is from the atria of the heart. And natriuretic peptide is basically a hormone that helps to get rid of sodium. Natriuresis means to get rid of sodium. So we get lots of loss of fluid, diuresis, and this helps to reduce overall blood volume and thus overall blood pressure. So this is kind of working at counter or opposite to what's happening with norepinephrine and renin release. Now, it's important to note that ANP release is the only release which is always beneficial. Remember, norepinephrine and renin release over time are no longer beneficial. And even though the ANP release is beneficial, it's really overwhelmed by the total amount of norepinephrine, renin, and aldosterone that's released. So it kind of gets covered over in the wash, I guess is the way to put it. Other ways the heart can compensate, you guys remember the Frank Starling principle, which says that the more I fill the heart, the more I fill a heart chamber, the more that chamber stretches, the greater the strength of the contraction when it does contract to move that blood out. That allows the heart to compensate somewhat for reduced contractility, but over time it actually decompensates. And the reason for that is that the more you stretch the heart myocytes, over time you get cytoskeletal alterations. Some of the myocytes even undergo apoptosis. You get altered extracellular matrix, remodeling of the extracellular matrix, and all of these together contribute to a loss of compensatory mechanisms from the Frank Starling law. Another way the heart can compensate is through hypertrophy. No surprise, the heart probably is going to get bigger, you would think, if it's getting stimulated to try to pump harder. Of course, one of the ways it might do that is to increase the size of the individual myocytes. With hypertrophy, there's a problem though. When I increase the size of the individual cells, I increase the oxygen demand of those cells. And that's a problem because typically the number of capillaries does not increase. The number of capillaries stays the same or may even actually decrease as the tissue hypertrophies. And so overall, even with hypertrophy, you're going to end up having potentially ischemic heart damage and also a reduced contractility because those enlarged myocytes are no longer getting sufficient oxygen to supply them and help them do their job. One interesting side thing, I don't think your book mentions it, but that can happen with patients with congestive heart failure is they can get what's called cardiac cachexia. This is kind of similar to what we learned about with cancer cachexia. We think, and again, I'm saying we think because there's still some research out on this, but that the main players involved in this is heightened release of tumor necrosis factor alpha and interleukin 6. In addition, there are some other chemicals that are getting released, but these contribute to weight loss and weakness, as we saw with cancer. It also can cause myocyte remodeling and apoptosis. Now, why these large amounts of, for example, tumor necrosis factor alpha, interleukin 6, and other chemicals get released is an item up for debate. There's at least 3 major hypotheses to try to explain why these get released, and that's far beyond the scope of this class. Okay, I think that's all on heart compensation. Now, there are two different types of congestive heart failure. Left-sided congestive heart failure, right-sided congestive heart failure. Left-sided congestive heart failure is probably, well, I don't want to say it's more common. I won't say that. It's most commonly caused by myocardial infarction. I can say that. That's true. Okay, so myocardial infarction can often lead to left-sided congestive heart failure. So that's myocardial infarction is a direct result of ischemic heart disease. If I'm not getting sufficient oxygen, of course, to the heart tissue, that heart tissue can die. Other causes can be somebody has chronic hypertension. They might have a damage to one or more valves of the heart, or they may have some sort of genetic abnormality of their myocytes in the first place that maybe reduces their contractility strength, for example. Left-sided congestive heart failure means that it is, as the name implies, the left side of the heart that is failing to meet the cardiac output demand that it should. So it's not contracting with great enough strength, and it's not pumping enough blood out into the systemic circuit. So what's the morphology? Well, if a person has left-sided congestive heart failure, obviously the heart's probably going to hypertrophy in response to try to counteract the loss of contractility. And we already talked about the fact that that can lead to problems in and of itself because of not enough capillaries and blood to supply oxygen to the enlarged heart cells. Oftentimes the ventricle will become dilated. It'll become enlarged. That's a very common feature of left-sided congestive heart failure. And this is the big thing. Think about the fact that blood that's entering into the left side of the heart came from the lungs. So if the lungs are supplying blood to the left side of the heart, and the left side of the heart is not pumping all that blood out into the systemic circuit, we start to get a buildup of blood behind the point of the problem. Okay? So behind the left ventricle, we get a buildup of blood. That blood builds up in the pulmonary veins, which means it then builds up into the lungs, and it can even build up all the way back into the right side of the heart. So the biggest impact left-sided congestive heart failure has is on the pulmonary circuit, the lungs. That's the immediate point upstream from the left side of the heart, if you will. So people that have left-sided congestive heart failure are going to demonstrate some symptoms that are indicative of a buildup of pressure and blood in the lungs. They'll often have a wet cough due to the fluid buildup in their lungs. They'll often have dyspnea, or an inability to breathe easily. They'll have orthopnea, which means that when they're in a lying down position, they have difficulty breathing. They'll have increased heart rate or tachycardia. Oftentimes, because the left ventricle dilates, remember we said it kind of stretches out, the chamber enlarges, that means that the mitral valve doesn't seal properly anymore. The flaps of the mitral valve can't touch each other anymore because the ventricular chamber has stretched so much. And so you'll get mitral regurgitation of blood into the atrium, right atrium, and you can even get right atrium fibrillation. All characteristic symptoms of left congestive heart failure. Now compare that with right congestive heart failure. In right congestive heart failure, now it's this side of the heart, the right atrium ventricle, that is not pumping sufficiently to meet the needs of cardiac output. It's not forwarding the blood into the lungs as it should. The most common cause here is left ventricular failure with pulmonary congestion. So in other words, usually what happens is the left side fails. We start to get this massive buildup of blood and pressure in the lungs. That puts additional pressure onto the right side of the heart, and suddenly it's not able to contract with great enough strength to overcome that afterload. And as a result, the right side begins to fail. Now, that's not the only cause, it's just the most common cause. Sometimes people can have chronic obstructive pulmonary disorders, for example, and that can lead to problems. So parenchymal diseases of the lungs can lead to right congestive heart failure. Vascular diseases in the lungs can also lead to this. Anything that increases the afterload of the lungs, afterload in the lungs, is of course going to increase the amount of work that the right side of the heart has to do to try to overcome that afterload to get blood into the lungs. Now, if I have right congestive heart failure, the backup is going to be upstream, behind the point of failure. So in this case, it's going to be in the venous circuit where I'm going to see the greatest amount of fluid buildup, blood buildup, hypertension, etc. So a very common thing that we see, the biggest impact is just in the systemic circuit behind the right atrium and right ventricle. Congestive hepatomegaly is a big problem. That means that I get a huge amount of fluid accumulation in the liver to the point where the liver actually increases in size. Pleural effusion. Sometimes we'll get that accumulation of fluid in the pleurae. And a big one, you'll get lots of peripheral edema, particularly in the lower extremities like the ankles and lower legs. Okay, that's enough on congestive heart failure. The next thing we're going to be talking about is arteriosclerosis.